Assalamu alaikum and good afternoon. I welcome you all to my today's topic, molecular imaging pathway in non-small cell lung cancer from initial staging to long-term surveillance. I am Dr. Rawnak Afrin, working as Associate Professor in Institute of Nuclear Medicine and Allied Sciences, Dhaka, under Bangladesh Atomic Energy Commission. Lung cancer is one of the most aggressive malignant tumor with high rates of morbidity and mortality worldwide. Non-small cell lung cancer accounts for about 85% to 90% of lung cancer. Several factors, including histopathological variety, stage at diagnosis, and treatment modality, are linked with the prognosis as well as with the survival. Finding new diagnostic and prognostic approaches is critical for improving the capacity to predict outcome. Adenocarcinoma, squamous cell carcinoma, and large cell carcinoma are the subtypes of non-small cell lung cancer. Until now, these are the available treatment options for a patient with lung cancer. PET-CT is a molecular imaging technique which combines in a single gantry a positron emission tomography scanner and a CT scanner. Molecular imaging has emerged as a transformative approach in lung cancer, enabling the visualization of biological process at the molecular and cellular levels. This is an ideal layout of a PET-CT facility. And these are the operational radiation dose during PET-CT scan for a patient and PET-CT staffs. Bangladesh Atomic Energy Regulatory Authority is the regulatory body to carry out regulatory and safety functions with regard to nuclear power generation and use of ionizing radiation in the country. Fluorine-18 FDG is the most common tracer used in PET imaging for oncological cases including lung cancer. It is a sterile, non-pyrogenic, colorless and clear fluid. The radioactive purity must be greater than 95% to make it suitable to administer into human body. And it should be used within 12 hours from the end of synthesis. And it is nothing but an analog of glucose. In the normal glycolytic pathway, it behaves similarly to glucose. But once phosphorylated, a special mechanism, metabolic trapping, happens, and this resulting in increased uptake and accumulation of FDG within abnormally metabolizing tumor cells. From synthesis to disposal, transportation, scan, in every stage we follow the standard International Atomic Energy Agency guideline. Whole body PET scan is acquired from vertex to mid-thigh in a whole body PET-CT scanner with top ingenuity 1 hour after intravenous injection of 5 to 10 millicurie of fluorine-18 FDG. And these are the common view for a oncological PET imaging. As poor patient preparation leads to poor images, so adequate patient preparation rules are strictly followed. 8 to 12 hours empty stomach prior scan, patients are advised to keep hydrated, avoid caffeinated beverage, take protein-rich diet, low carbohydrate, avoid exercise, journey, and take rest after administration of FDG. We usually use contrast during PET-CT scan and image itself express why contrast is needed during a PET-CT scan. Written informed consent was taken from every patient and a special instruction paper was also given to the patients. And these are the checklist we need to have in our hand before a PET-CT scan and doing a report. These are the common tumor parameters evaluated in FDG PET-CT, that are metabolic tumor volume, SUVmax, mean, total lesion glycolysis, and others. Metabolic tumor volume refers to the metabolically active volume of the tumor segment using FDG PET. It exhibits greater accuracy in predicting progression-free survival and overall survival. And standardized uptake value is most commonly used parameter in FDG PET-CT scan. These are the common physiological uptake sites in a PET-CT scan, and uptake in brown fat is also a common phenomenon during cold weather in case of female lean body weight patient and in case of children. The evaluation of pulmonary nodule provides a unique challenge for combined PET-CT scanning due to difference in breathing pattern between CT and PET acquisition period. Misregistration is particularly evident at the lung bases, resulting in difficulty differentiating pulmonary nodules from focal liver lesion. Here we can see a nodule in the right lung base, but in case of CT, there is no lung nodule. This lesion is in the superior aspect of the liver. So it is due to misregistration artifact. Radiation pneumonitis is another concern. Inflammatory morphological changes in the radiation field post-irradiation of primary or metastatic tumor can result in false positive diagnosis. So it's important to elicit a history of radiation from the patient and to correlate the increased uptake with the CT findings to avoid missing a disease recurrence. These are the common features of a radiation pneumonitis in a post-radiation field. Indeterminate pulmonary nodule or beyond PET reduction. When lesions are smaller than 1 centimeter, may not show increased uptake in the lung or mediastinum. This is the result of the 1 centimeter resolution of PET-CT system frequently used, and special resolution limitation of FDG PET have been shown to be the causative factor of false negative PET scan. 9th TNM classification for lung cancer is now used for the imaging, and it provides a standardized nomenclature for describing the anatomic extent of the disease, facilitating consistent communication regarding patient outcome and the applicability of clinical data to individual cases. And this applies both non-small cell and small cell lung cancer, but it does not apply to pulmonary sarcoma, lymphoma or other rare cases. And from 8th TNM to 9th TNM, there is no significant change. T component has no change, N component has a little change, and M component has a little change. In a T1 staging, the tumor is less than 3 centimeter. T2, the tumor shall be less than 5 centimeter. Or might be invade the visceral pleura, involvement of the bronchus or other changes. These are the T3 classification, and in a T4 classification, the tumor has to be more than 7 centimeter, or there should be other parameters: invasion to trachea, superior vena cava, invasion to adjacent vessels or diaphragm. There shall be synchronous tumor or separate tumor nodules may be found. In case of synchronous primary tumor, the TNM staging should be separated for each tumor. And these are the N staging for nodal mapping in a PET-CT scan, and these are all the 1 to 14 stations for a TNM staging mapping. And in case of TNM staging, M refers to distant metastasis. M1 means distant metastasis. That may be a single distant metastasis site or a other distant nodal metastasis. And M1B should be single extrathoracic metastasis in a single organ system or a non-regional lymph node metastasis. And M1C indicates multiple extrathoracic metastasis in a single organ. M1C2 means multiple extrathoracic metastasis in multiple organ system. Role of PET-CT in management of non-small cell lung cancer. PET-CT can accurately pre-staging in a baseline lung cancer patient. Here is a 60 years male patient, histologically proven case of adenocarcinoma of left lung, and we can clearly see a hypermetabolic mass in left upper lobe, and this patient has no other nodal, visceral or skeletal metastasis. So the patient is stage 1 and the patient is opted for surgery by the tumor board. And in a 50 years female patient presented with cytologically proven case of squamous cell carcinoma in right lung, this patient show a small lesion in right lung, but there is another hypermetabolic lesion in left upper thigh. And in case of axial imaging, the primary lesion is very small, that is in the anterior segment of right upper lobe, and there is tiny nodule in right lower lobe, another tiny nodule in left upper lobe, and there is a large mixed density mass in left upper thigh and also a nodal mass. We reported it a case of metastatic lesion, and it is confirmed by histopathology as a metastatic squamous cell carcinoma. So the patient in baseline scan has stage 4 disease, and the decision for surgery changed, plan for systemic chemotherapy. A PET-CT also can be used in searching for unknown primary when patient presented with metastatic disease as the first manifestation. A 70 years old male patient presented with hepatic metastasis and pathologically proven as metastatic poorly differentiated adenocarcinoma. PET-CT can detect the primary tumor in right lung, and this patient PET-CT also, baseline PET-CT also reveals extensive hepatic metastasis, other skeletal and nodal metastasis site. So PET can detect the extent of the disease more accurately than conventional imaging. And the right lung lesion is histologically proven as primary malignant lesion in this patient. FDG PET-CT can guide in selection of the region of tumor for biopsy. It plays a critical role in selecting the optimal region for a lung cancer biopsy by identifying areas of the highest metabolic activity, avoiding non-avid necrotic tissue. It can distinguish tumor from collapse. PET-CT clearly separates the metabolically active tumor from the collapsed lung or post-obstructive pneumonia and select alternative safer biopsy site. Here we can clearly see the metabolically active site, so this will be the site of choice for biopsy. PET-CT can help in guiding radiation therapy planning. It improves radiation therapy treatment planning and dose delivery as undetectable lymph node involvement, uncertain primary tumor extension, and oligometastatic disease become readily visible in a PET scan. Tumor underdosing is avoided in patients with atelectasis and pleural effusion. Radiation treatment fields are appropriately adjusted. FDG PET-CT could discriminate more accurately whether the residual disease is a metabolically visible tumor or scarring. In first cases, a patient with squamous cell carcinoma, after therapy, the PET can detect the disease recurrence after chemoradiotherapy and metabolically active tumor is here. And in second patient, in a patient with adenocarcinoma lung, PET can detect the inactive fibrotic scar after radiotherapy. There is no metabolically active tissue. Dual-time PET imaging is a potentially promising method for distinguishing malignant versus benign or inflammatory lesion. The SUV value initially after 60 minutes of radiotracer administration and over time, that is 120 minutes after administration, provides a better way to differentiate between benign and malignant lesion. Lesions with decreased or stable SUV over time are likely to have benign etiology, and in contrast, lesions with increased SUV over time are likely to be caused by the malignancy. Here we can see a same patient after 60 minutes of administration of radiotracer, and it is 120 minutes of administration of radiotracer. We can clearly see here the radiotracer uptake is more increased in the dual point PET-CT, so it is more confirmatory for a malignant lesion. PET-CT can clearly identify complete metabolic response, partial metabolic response, progressive metabolic disease, and stable metabolic disease. And the era of precision medicine, the optimization of oncological patient management with early and accurate tumor response assessment is very crucial. Complete metabolic response, in this patient we can see the complete metabolic response. It is the baseline scan and it is after therapy, and it indicates that complete resolution of FDG uptake within the measurable target lesion, disappearance of all other lesions to the background blood pool level, no new suspicious lesion. But if progression according to RECIST criteria must verify with follow-up scan. Partial metabolic response means a reduction of minimum 30% of the metabolic activity and no new lesion. And in a stable metabolic disease means no progressive disease or no complete resolution and no new lesion, that is the lesion is stable at baseline and post-therapy. And progressive metabolic disease indicates more than 30% increase in metabolic activity than the baseline scan, or visible increase in the extent of FDG tumor uptake or any new lesion that is FDG avid. PET can bridging imaging to therapy. It can monitor therapy response, detect recurrence rate and restaging. A 52 years old male patient presented with pathologically proven adenocarcinoma lung and was stage 3A. His EGFR mutation was positive, that is 19 deletion. In baseline scan, we can see a hypermetabolic mass in right lung and also a same-sided nodule, ipsilateral lung nodule. Follow-up scan after completion of chemotherapy and oral targeted therapy, this patient show complete resolution of the primary malignant lesion, leaving behind a non-avid fibrotic scar. This patient was progression-free survival for 24 months and shown no new lesion in the follow-up scan. But after 24 months, this patient developed a new lesion in right lung. So at that point, we do a dual-time PET-CT scan to confirm it as a malignant recurrence. And after giving radiotherapy, this patient showed resolution of this lesion. Another 65 years old male patient presented with pathologically and immunohistochemistry proven adenocarcinoma. The mass was in right lower lobe, the wild type EGFR mutation, and this patient underwent right lower lobectomy on October 2022. And this patient showed no local recurrence or distant metastasis. And in follow-up cases, the patient showed no distant metastasis, no locoregional recurrence. The patient was disease-free for 42 months. After 42 months of follow-up, the patient developed a large heterogeneous hypermetabolic mass in left kidney and also having tumor thrombus. We reported this case as a second primary, and this case was histologically proven as a new type of second malignancy, that was papillary type of left renal cell carcinoma. Another patient, 62 years old female patient. This patient underwent bilobectomy in 2020, and this patient had EGFR exon 19 deletion, and this patient was on oral targeted therapy from November 2020. This patient underwent serial follow-up and had no distant metastasis or locoregional recurrence. And this patient was disease-free up to June 2025. And then the patient showed marked disease progression. The patient develops mediastinal lymph node, multiple hepatic metastasis, left upper abdominal metastatic mass, and also skeletal metastasis. But after giving 4 cycles of platinum-based chemotherapy along with oral TKI, this patient show morphometabolic regression of hepatic metastasis, skeletal metastasis. And another 64 years old male patient. This patient had mass from right upper lobe, that is squamous cell carcinoma, and a single right hilar lymph node. This patient was treated with chemoradiotherapy. After 1 year, this patient showed progressive disease, and that is marked disease progression. This patient showed stable disease in locally, but this patient developed multiple nodal disease, multiple skeletal lesion, and also developed a new lesion in medulla oblongata region, multiple abdominal lymphadenopathy, and also a lesion in the spinal cord region. And this patient, after 15 days of his second PET-CT scan, expired. And in some of our previous research, a multicenter study for lung cancer, we showed that treatment plan changed in 40% of the study patient after baseline PET-CT scan, including thoracotomy. And PET-CT scan revealed 98% sensitivity, 94% specificity, 97% accuracy, and 98% positive predictive value in pre-treatment staging of non-small cell lung cancer patient with stage 4 disease. And SUVmax value was relatively higher in squamous cell variety than adenocarcinoma. And EGFR, another study, EGFR positive patient was 40% in a total 80 patient, and 60% revealed EGFR wild type. EGFR mutation is relatively higher in Bangladeshi population, and it makes the lung tumor sensitive for EGFR tyrosine kinase inhibitor therapy. And among the EGFR mutation positive patient, about 90% patients show classical EGFR mutation. SUVmax value was higher in the patients having wild type EGFR than the mutant group. The size of the primary malignant lesion, staging of the patient was higher in EGFR wild type. EGFR mutation found more in non-smoker and female patient among Bangladeshi population. We are now aiming to find out the association between metabolic parameter, that is metabolic tumor volume and total lesion glycolysis of FDG PET-CT with oncologic driver gene mutation in lung adenocarcinoma patient. And we want to predict the progression-free survival and overall survival on the basis of this parameter, and this is our ongoing study. Several breakthrough radiotracers have emerged to improve the diagnosis of patient stratification and treatment monitoring of non-small cell lung cancer by moving beyond traditional FDG metabolic imaging. These novel tracers target specific molecular alterations, immune checkpoints, and tumor microenvironment marker to pave the way for precision oncology. Immune checkpoint tracer. As immunotherapy becomes a standard pillar of non-small cell lung cancer, evaluating immune marker landscape non-invasively helps clinicians predict treatment response and distinguish true prognosis from pseudoprogression. 68 gallium THP APN01 is that type of tracer, and another tracer is 89 zirconium alpha PD1, and these are all on that clinical trial phase. Rather than analyzing tissue from isolated biopsy, this tracer provide a non-invasive whole body mapping of actionable genetic driver. Fluorine-18 IRS and fluorine-18 FET20 are the novel PET radiotracer specifically designed to bind the mutant EGFR tyrosine kinase domain. They match active mutation profile like exon 19 deletion or L858 are optimizing selection for EGFR tyrosine kinase inhibitor therapy. Fluorine-18 FED20 PET-CT imaging act as a non-invasive tool to identify patient carrying targetable active EGFR mutations and monitor their response to tyrosine kinase inhibitor therapy. These are now in clinical trial phase. It is a imaging feature of gallium 68 THP APN08 PET-CT. So, FDG PET-CT is essential in pre-treatment staging of non-small cell lung cancer, notably mediastinal nodal staging and distant metastatic survey. The use of PET-CT for pre-operative staging of non-small cell lung cancer can reduce both the total number of thoracotomies and the number of futile thoracotomy. It is an excellent tool for response evaluation, re-staging after neoadjuvant treatment, detecting tumor recurrence, and guiding radiation therapy planning. Pre-treatment SUVmax value and metabolic tumor volume of the primary lung lesion on PET-CT is significantly associated with prognosis and overall survival in patients with advanced non-small cell lung cancer. Clinical use will continue to grow with the increased use of new tracer. This rapidly growing field combines diagnostic and therapeutic agents that target the same molecular pathway, enabling personalized treatment strategies. These are the references of my presentations, and thank you all for your kind attention.